Jennifer Moore Ballentine, MA, is a longtime national palliative care advocate and educator who has served as executive director of the CSU Shiley Haynes Institute for Palliative Care since 2017. In the past 20 years, she has published numerous articles on palliative and end-of-life care in peer review and trade journals. She has delivered more than 600 workshops, grand rounds, webinars, and in-service training programs, developed, planned, and executed 14 local, state, and national conferences, and created 5 comprehensive multi-part educational programs. Quite an achievement. Ms. Moore received her BA from Oberlin College in Ohio, and then her master's degree in end-of-life and education studies from Regis University in Colorado in 2005, graduating summa cum laude with her thesis on matters of life and death, an indigenous model for community-based end-of-life education. She is the former executive director of the Life Quality Institute in Denver, Colorado, and she has subject matter expertise in hospice, palliative care, healthcare ethics, advanced care planning, pulsed paradigm, medical aid in dying, and healthcare policy. Please join me in welcoming our expert, Jennifer Moore Ballentine.
Goodness, good morning, everyone. You left off the last line of that, which is, but however, I can't sing. so just so we're clear on that. It's a great pleasure to be with you all this morning on All Saints Day, which is very appropriate for our topic. I'm going to go ahead and share my screen. I do have some slides for you today and get this going from the beginning. So can you all see that?
Yes. Oh, wait, coming on. There we go.
Okay, good. And I hope the animation works. Okay. So delighted to be with you. And we're going to talk today about the promise and the pitfalls of palliative care. You may end up at the end of this knowing far more than you ever needed or wanted to know about palliative care, but that will be my gift to you. So let's see if we can advance the screen here. All right. So today I'm going to give you a little bit of history, because I always like to start at the beginning, give you some context for what palliative care is and where it actually occurs and how you might recognize it when you see it. And then talk a little bit about the promises of palliative care, the pitfalls of palliative care, and ultimately what it means for you as citizens of the world. So where it all began, it is All Saints Day. This would be even yet more appropriate if we were talking about this on All Souls Day, but here we are. And it's relevant because every culture and major religion has some particular way of honoring their dead and of ritually recognizing life transitions, big and small. And particularly the transition from life to death is probably the biggest transition that we go through consciously. So there are many, many ritual responses to this process, as well as now in the modern era, medical responses. These are images from the 2 best known documents of managing that transition from life to death, the Egyptian Book of the Dead and the Tibetan Book of the Dead. When we think of these things, we tend to think of them in the Eastern tradition, but there is, in fact, a Western tradition of companioned dying. It all began on the islands off the west coast of Ireland. Some of you may recognize this as the islands on the planet Ahch-To in the more recent Star Wars film. These are, in fact, the islands of Skellig Michael. And on these very, very sharp spiky peaks, there was a monastic community that was founded in about 588 CE. And the monks there, as the early Christian monks did, sort of adopted some of the Celtic pagan practices of the time and a worldview that imagined that there are in some parts of the world, quote unquote, thin spaces where the division between life and death becomes very, 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 very thin and impermeable. And the monks at this particular community developed a specialty in helping people to learn how to die. In these shell, sort of shale huts that were built on Skellig Michael, the monks would actually take pilgrims through a process of imagining their dying and coming to terms with what their life meant, what they had done, what they had not done, and how to spiritually prepare for the transition to the other world. So there is indeed a rich tradition in Western Christian ritual, having to do with companioning our dying. More recently, of course, it's mostly become a medical process. But from this early medieval or even Dark Ages methodology, we moved to the high medieval response. And this sort of coincided with the waves of Black Death that swept across Europe in the 14th to the 16th century and decimated the priestly classes just as much as everyone else. And this is becoming I have to say my spiel about the Black Death has become much more present and meaningful over the past couple of years. But in this time, when many millions of people were dying across Europe, the exercise of dying as a spiritual practice had to become more of a DIY practice. And there were whole literatures written that would help individuals and a lay companion, not necessarily a clergy companion, work through that process of confronting temptations, confronting the sort of making amends for things that they had done wrong in their lives, and really spiritually preparing and physically preparing for the end of life. The Ars Moriendi literature, which this is a page from one of the pamphlets, and you can see that there's some text here, but it's mostly illustration for a mostly illiterate population, actually became Gutenberg's bestseller. And many millions of these pamphlets were written and were adopted and used by the population of Europe as they confronted death on a daily basis. This sort of transferred into the medieval hospice tradition. Hospice and palliative care both harken back to this earlier tradition. Hospice comes from the word hospitium, which denotes a place, not a place, but a relationship between guest and host. Palliative comes from palliare, which means to cloak or to shield. And the original hospices were a medieval system of havens and guest houses, many of them attached to monasteries or nunneries that were havens for travelers, for the wandering poor. Some were founded by itinerant Celts from Ireland. And today, hospice shares more than just a name with this tradition. The original hospices were havens for the ill and the dying. They really served as the first community hospitals, the first charity hospitals. And one of the unique things about the approach to handling suffering and illness and death, even in this time, was a recognition that not all pain is physical, that there is something called soul pain. And in fact, the soul pain was the primary diagnosis. And this is a page from a customary, medieval hospice customary that sort of lays out some of the instructions about how to manage some of this soul pain with, and you'll notice there are little notations in the margin. So this tradition was handed down and handed across many of these medieval hospices. The idea was that you first find the soul pain and you heal that, such as a reluctance to forgive, a broken relationship, trauma of some kind, or fear, or regret, or grief. And if you can heal the soul pain, then the body will either heal as a consequence of that, or the person can at least die in peace. So the preparation for dying was physical, it was postural, as much as emotional and spiritual, and it was developed from a sort of passive waiting for death into a very active engagement with the process. So now we fast forward to the 19th century, and we come to Greenwich Village in New York, where a group of women who were inspired by a monastic or a nunnery order in Europe to care specifically for terminally ill women in particular, founded what they called the House of Calvary. And it was originally placed in two brownstones in Greenwich Village and later moved to the Bronx in 1915. The House of Calvary was accredited as a hospital in 1965, and it's the only hospital in the United States solely focused on palliative care. They added home health care in 1991 and outpatient hospice in 1998. I include this because most people tend to think that the modern hospice movement or the modern palliative care movement started actually in Britain, which we're going to get to in a second, but the Americans were first. So in Britain, a remarkable woman named Cecily Saunders, who was a nurse at the time at a cancer hospital in the 1940s, 1950s, when there really weren't very many effective treatments for cancer, was very, very disturbed about how patients with terminal illness were treated, or rather not treated, that they tended to be medically and even personally abandoned, sort of isolated on wards for the dying, and their pain was not even much paid attention to. And she thought this was, pretty abominable. And so she began to think about how a different approach could be brought to the treatment of dying. These people are not going to get better, they're not going to be cured, but nevertheless, we ought not to stop caring for them. And she hearkened back to this original model of the medieval model of hospice that really looked at an experience of pain that was, as she came to call it, total pain. That pain is physical, absolutely, but it also is there, it can be mediated, made worse or better, perhaps, by spiritual, emotional, psychological, social, and relational factors, that we experience pain multidimensionally. Excuse me. And as we experience pain multidimensionally, the treatment should be multidimensional and should draw on the expertise of a number of different clinicians, not just physicians. Sorry, morning voice. So across the pond, back in the US, at the same time that Dame Saunders was founding the first hospice, St. Christopher's Hospice in the UK, Elizabeth Kubler-Ross was doing her work. She was a psychiatrist at the University of Chicago, and a group of divinity students from the Chicago Divinity School came to her and said, we're really interested to know what the actual experience of dying is like. And as you have access to dying patients and you know something about the brain and emotional, psychological kinds of approaches, will you help us do this study? Well, that's what morphed into a huge study that became ultimately her very famous book on death and dying. And it was indeed one of the first qualitative phenomenological studies of the actual experience of dying. And she found very similar findings to Cecily Saunders, that patients who were dying, and this is the 1960s, when we're starting to have some better treatments for these eventually terminal illnesses, but the treatments in some ways are just as lethal as the illnesses. Most of the people who were dying were kind of abandoned. They were not looked after well, their pain was not managed well, and anything having to do with their psychology or their emotions or their spiritual care was not paid attention to at all. So she wrote up her study and identified the very famous 5 stages of grief, but what she was really wanting to do was bring attention to the inadequate care and even neglect of dying patients in the US, and really calling for a different approach. At the same time, 1960s, lots going on, Florence Wald, who was the Dean of Mental Health and Psychiatric Nursing program at Yale, had heard Cecily Saunders speak about hospice/palliative care, was very inspired, and in 1964 went over to the UK and interned with Cecily Saunders and wanted to bring the model of hospice back to the United States. However, as you may know, the US health system and the UK health system are very, very differently constructed, and there was no place within the US health system to really slot a hospice model. So instead of that, she decided to found a volunteer organization. Connecticut Hospice, excuse me, was opened in 1974 as an all-volunteer effort. Physicians, nurses, social workers, chaplains volunteered their time to care for patients in their homes because there wasn't an ability to start a facility for hospice care at that time. They were caring for patients primarily in their homes. And in fact, that has remained the primary model for hospice care throughout the United States. So this model caught on, and in 1979, the Healthcare Financing Administration launched 26 hospice programs around the country as a demonstration project to really see what the effects on patient care and, by the way, on cost this new model might have. With favorable results in 1982, Medicare established the Medicare hospice benefit and began to cover hospice services. And by 2019, there were almost 5,000 Medicare certified hospice agencies across the country. Meanwhile, up in Canada, any of you been to Canada? This is Mount Balfour. I have not been there, but it looks quite dramatic. Mount Balfour up in Canada. And this is Dr. Balfour Mount. Now, any relationship, I don't necessarily know, but I just kind of throw that in there as a point of humor. But Balfour Mount was a urologic cancer surgeon who indeed also was inspired by both Cecily Saunders and Elizabeth Kubler-Ross. And he did a similar study at his hospital. He was at Royal Victoria Hospital, and he did a similar study on the experience of dying patients, found the same thing. These folks were not being well cared for. So he too visited St. Christopher's Hospice and interned with Cecily Saunders and wanted to bring the model back to Canada. Now he too, because the Canadian system is yet more different, knew that he couldn't probably establish a network of freestanding hospices. So he launched a pilot project in 1975-76 to provide inpatient palliative care for the seriously ill, though not necessarily dying patients in the hospital. And he coined the term palliative care to distinguish his model from the hospice model. Palliative care, the etymology being to cloak or to shield, and to reduce the violence or intensity of, to improve the quality of care. Royal Victoria Hospital in Montreal had the first fully comprehensive palliative care program. And then it was re-imported back to the United States, starting in Cleveland Clinic and most of the academic medical centers. So we now have two sort of models of palliative care going on. We have the hospice home care program for primarily terminally ill patients, and we have palliative care, which is mainly focused in the inpatient setting on patients who are not necessarily dying, but have very, very serious illnesses and perhaps have some questions that they have and issues to deal with and ways to plan. So 2006, hospice and palliative care was recognized as a formal subspecialty, and the first board certification exam was in 2008. So why is all this important? The medical technical model of medicine that was developed in the beginning in the 19th century and full bore in the 20th century is really entirely focused on cure. All of the treatment from diagnosis of a serious or progressive illness is really focused on curing that disease. And if we can't do that, at some point we get to a place where, whoop, sorry, oh, yep, nothing more we can do, and you're dead. That was the medical technical model. And that leaves us with this kind of horrible situation of you've got 6 months, but with aggressive treatment, we can help make that seem much longer. Funny, not funny, because this really is the experience of many people who have terminal or serious or progressive illnesses that cannot be cured, but nevertheless, the treatment continues and continues and continues, and it just doesn't necessarily achieve a positive effect, and in fact, can impose additional suffering. So then, with the introduction of hospice, we get kind of a different model that includes different alternatives, but it's still kind of linear and it's still kind of siloed. So we have that curative intent going on. And then there's this kind of intermediate phase that involves a lot of home care and rehab. If any of you have been in the hospital for a serious illness or let's say a knee replacement or a hip replacement, you end up going to rehab. And in rehab, you work on improving or maintaining your function. And if you can't improve or maintain your function, you might stay there in long-term care, but mostly you end up going home and things go along for a little while. But in some cases, with some illnesses, this kind of becomes a little bit of a revolving door, between the curative intent and then the home care and the rehab and back in the hospital and so on. But then we have hospice, and eventually, if the right stars align, people might then be referred to hospice and receive really good gold standard quality care for the last 6 months or so of their lives. And then following death, bereavement care, which is very, very important for their loved ones and family. So this is a better model. There are more choices here. There's more attention to the symptoms and stress of a serious illness, but it's still kind of all going in one direction. The integrated palliative care model has that same curative intent, because absolutely we do want to do what we can to cure the disease, but starting at the diagnosis, we hope, palliative care comes right alongside, and it pays attention to symptoms and stress and the emotional concerns, relational concerns, practical concerns, spiritual concerns of people who are dealing with a very, very serious illness. And it can continue right through the home care and the rehab and the long-term care phase until perhaps when there is a transition to hospice, it's not so abrupt. It's not suddenly, oh, nothing more we can do on the cure, here's hospice. But it's been an accumulation of more focus on the palliative and less focus on the curative over time. So as I say, that transition to hospice is not so abrupt. And then there may be a moment, inevitably, when the person passes away, and then bereavement care can follow. Now, ideally, palliative care would start at diagnosis of a serious illness, whatever that might be, whether it's ultimately terminal or not. As a practical matter, it should then, if not at diagnosis, it should certainly be introduced at home care and rehab and long-term care. But as a practical matter, unfortunately, it doesn't really get introduced until pretty close to when a person might actually be eligible for hospice, but for whatever set of reasons isn't ready or the physician isn't willing to refer. So a lot of the goal in palliative care these days is to try to move it further upstream, to get palliative care being offered and being provided sooner, closer to that diagnosis of the serious illness and not so far along in the process. So what is palliative care? It is specialized medical care for people living with serious illness. It's focused on providing patients with relief from the symptoms and stress of a serious illness, whatever the diagnosis. And that's important, whatever the diagnosis, doesn't matter if it's terminal or not. The goal is to improve quality of life for both the patient and the family. And it's provided by a team of doctors, nurses, and other specialists who work with your other doctors. It's not an either or, it's a both and, to provide an extra layer of support. Palliative care is appropriate at any age. Children receive palliative care, and at any stage. Doesn't have to be terminal in a serious illness. And it can be provided along with curative treatment, whereas in hospice, that's not always the case. The domains of palliative care are really the two major domains are pain and symptom management and advanced care planning goals of care. The pain and symptom management is pretty self-explanatory, except it encompasses all of those dimensions, not just physical pain. Advanced care planning really is a process of helping patients to identify what's important for me and how I am cared for and how I want to live my life, and what treatment choices are important to make ahead of time or in the moment in order to preserve my goals and to get to where I want to be in my healthcare, not where anyone else wants me to be. In addition to that, palliative care offers psychosocial support, spiritual support, ethical decision-making, which, there are lots and lots and lots of decisions that have to get made in the context of a serious illness, and palliative care can really help with that. Not only you, but your doctors and your healthcare providers. Care coordination, making sure that the right hand knows what the left hand is doing and that transitions between those various settings are handled smoothly. Hospice is palliative care, but not all palliative care is hospice. Hospice is a specialty level of palliative care. That's one way to think of it. So what are the differences between hospice and palliative care? Oftentimes you kind of imagine, people sometimes get them confused. They don't really know where one starts and the other leaves off. So let's take a look at this. Hospice is focused on relief of suffering at the end of life. There is a requirement to enter hospice care that you be within 6 months of the end of your life based on a physician's considered opinion. Hospice offers 24/7, 365 services around the clock from the same provider. And this is one of the greatest benefits of hospice, actually, is that concierge function of being the one call that you have to make to deal with whatever is going on with the patient and their concerns. Hospice is currently available in any healthcare setting or private home. Hospice can be provided in a nursing facility, in an assisted living, in a private home, even in a hospital. It is regulated, certified, and accredited by Medicare and by other deemed organizations such as the Joint Commission for Healthcare. And it is a fully covered benefit by Medicare, many Medicaid programs, and many private insurance plans. So all of the costs associated with caring for the patient with relation to their terminal illness is covered by the benefit. So in palliative care, the focus is also on relief of suffering during any serious illness and not just at the end of life. It's often offered in the context of inpatient consultation with intermittent home care. It's available in many hospitals, but not all, some community-based programs and some facilities. There is uneven access and uneven quality. It is not currently reimbursed or paid for by Medicare, and regulation follows payment. So in the absence of a benefit or a payment for palliative care per se, there are not standards, there are not regulations, there's not a lot of consistency. It is minimally covered in a fee-for-service plan or by private pay. Now, some private insurance companies are standing up more robust palliative care benefits. Blue Cross Blue Shield is one of them. Kaiser is another that has a very robust palliative care benefit, and others. So they're catching up, but they're not quite there yet. I want to introduce a new sort of concept to you called trajectories of illness. And this is important when we're thinking about what illnesses does palliative care help with. What's a serious illness? When would palliative care be appropriate at any particular moment? And it has less to do with diagnosis than it has to do with what's called a trajectory. Now, a trajectory, if you remember your high school physics, has to do with the course of decline. A projectile is projected up into space, and depending on a lot of factors at that moment of projection, it declines according to a certain shape over a certain time. So that shape and duration, the path of the trajectory and the speed of the trajectory are determined by a number of factors at the beginning. And that's the shape of that arc is a trajectory. Now, missiles have trajectories. It turns out that illnesses have trajectories. And this metaphor was first sort of coined in a very important Institute of Medicine report of 1997, sort of looking at care at the end of life. There were 3 trajectories identified in that seminal volume. A fourth was added by Joanne Lynn, who is a very prominent researcher and palliative care physician in 2004. And there is a 5th trajectory shaping up that I actually thought of, and then some other people have been looking at it as well. So we have 5 trajectories of illness, and this is important because understanding the trajectory of an illness will help you to understand when palliative care and when hospice, and how to manage the advanced care planning that you need to do all along the way. So here is our first trajectory of illness. So how many of you, and you can just either think about this, raise your proverbial hand, or just nod if you're on camera. How many of you would like to die suddenly? The proverbial hit by a bus. I expect that there are some of you. So the first trajectory of illness really isn't a trajectory, it's a crash. So you're going along, living your life, everything is fine, and then there's something that happens very suddenly and boom, you're dead. Now, prior to the 20th century, a lot of illnesses were really effectively crashes. You might get a cold on Friday and be dead of pneumonia by Monday. Accidents, suicides are a form of crash. So people do die suddenly, but it's a small minority. It's only about 8% of us that actually die suddenly. So here's our next choice. Oh, actually, let me just mention, in a crash scenario, there's no need for hospice or palliative care, obviously. And you would hope that advanced care planning might have been done when the person is healthy, but because it's a good idea to do it and that they have a medical power of attorney in place. So next trajectory, we have Niagara Falls. So how many of you would like to die of cancer? Any takers? I'm guessing probably not very many. This is the trajectory for cancer. And in cancer, someone might be diagnosed with cancer and they might live a very long time, actually. Cancer is turning out to be, many cancers are turning out to be pretty manageable for a pretty long time with a series of treatments. And the treatments are not a lot of fun, but they can maintain a pretty good quality of life and a pretty good level of functioning for some period of time. But ultimately, most cancers it's kind of a tipping point and they kind of go off a cliff and then resulting in death fairly rapidly. Now, we understand cancer pretty well, and we know pretty well when things are going to happen along the way. Palliative care ideally should start with immediately at the diagnosis of any cancer. Hospice should start at that tipping point. And most physicians, most clinicians are pretty good at knowing when that is. And advanced care planning should happen all along the way, preferably before the diagnosis, but also at the diagnosis and as the person moves along the path and changes in their condition and changes in their goals might occur. Advanced care planning is not a one and done, it's a process. And it's a process that continues through the illness trajectory. So, cancer. Now, how many of you would like to die of organ failure? Organ failure takers, anyone? Organ failure includes things like lung disease, liver disease, kidney disease, other failures of heart disease, other failures of major organ systems. And the trajectory of organ failure tends to look kind of more like a roller coaster, where you're diagnosed and you immediately get some treatment, which tends to be symptom management treatment. And that can keep you going at a pretty high level of functioning, but then you'll have a crisis. And there's a whoop, you kind of have a dip, and you might end up in the hospital. This is also referred to as an exacerbation. You might have a crisis and a sudden worsening, and very likely, you're returned to a state of health. And you go in the hospital, you get some treatment, maybe you're on a ventilator for a period of time, maybe you get dialysis, and you're brought back to a level of functioning. And that goes along, pretty well for a little while. And then you have another exacerbation and you end up back in the hospital and you kind of go through that same thing again. And you have another recovery and you're returned to a level of function. Now you'll notice here that the trend is downward, that after every crisis, the level of recovery is never quite to baseline. There's usually kind of an overtime decline or degradation of a person's functioning after each of these crises. And any one of these crises can result in death. And eventually, one of them will. And the person will pass away. Now, how long this takes and what exactly the experience of that crisis recovery roller coaster is very individual. But the trajectory is very identifiable, and it is typical of organ failure kinds of diseases. Palliative care is essential throughout the progress of an organ failure illness. and you'll likely need frequent home care. You'll be in and out of the hospital, possibly in and out of rehab or long-term care. It's really hard to find the right moment to refer someone on this trajectory to hospice, and often it happens very late or not at all. Advanced care planning must go on, again, throughout the process here, as every time you go through one of those crises, every time you have some more treatment, to decide, do I want to continue to do this? Do I want to continue down this path? So about 36% of us die of organ failure, and I should mention about 21% die of cancer. So if you don't want cancer and you don't want organ failure and you're not likely to have a sudden death, here's what you get: the dwindles. This is the awful one. This is the one where there's just a really slow decline over time that is almost imperceptible but inexorable, and ultimately death occurs. This is very typical of dementias, not just Alzheimer's, but many other dementias. Something called failure to thrive, or as we sometimes say, TMB, standing for too many birthdays. Other neurological declines, all forms of dementia. About 10% of deaths these days are due to dementia writ large. About 6% due to, 4% of deaths are due specifically to Alzheimer's these days. That is likely to rise. The estimates now are that about 11% of people living over the age of 65 are now living with some degree of Alzheimer's disease and will ultimately probably die of it. So this is a bad one. And again, palliative care throughout the progress of the illness is an absolute must. Very likely long-term care will be needed, often in a specialized unit. And like the roller coaster, hospice referral is very difficult and often very late. It's very hard to know when a dementia patient is within 6 months of death. Advanced care planning is essential. Ideally, before the person exhibits any signs of dementia, they will have identified a medical power of attorney. That's the surrogate, who is able to make decisions for them and in according with their wishes all the way along the process as changes in condition occur, new comorbidities occur, and just periodic review. Oftentimes, a death from the dwindles is as a result of someone making a decision not to continue a particular treatment or not to even start a particular treatment, which is a very hard decision to make. So those are the four main trajectories, but it has occurred to me and others that there's a fifth one out there. And this fifth one is what I refer to as the bungee jump. It can also be referred to as the catastrophic event. And this is a case where someone's going along just fine, living their lives, and then they have some kind of major event, but it doesn't quite kill them. They have a heart attack, they have a stroke, they break a hip, they have some kind of major medical event that is not fatal, but seriously diminishes their ability to live independently, to live well, or to live consciously. Major brain injuries are catastrophic events. And as a consequence, the person does not recover significantly and may then sort of move into a dwindles kind of final trajectory ending in death. And I mention this because hip fracture in an elderly person is a bungee jump trajectory for many, many older people. 25% of people who have a hip fracture are dead within a year. 60% if they're older than 80. And only 25% of survivors of a hip fracture regain their pre-fracture level of function and mobility. And the remainder typically require ongoing supportive care, and other comorbidities tend to accumulate quickly. So stroke, brain injury resulting in coma, minimal consciousness, persistent vegetative state, but also hip fracture are catastrophic events that can really turn a person's life inside out. So these are the trajectories. And in bungee jump, again, palliative care throughout the process from that beginning crisis moment. Likely rehab and long-term care will be required. Hospice referral may be difficult, And here too, death may only come about as a result of withdrawal of life-sustaining treatment. So advanced care planning, you hope, is done prior to the event. We're subject to, any one of us is subject to having this kind of an event at any moment. So get your advanced care planning done. But at each intervention that's offered, each changing condition, the person who is identified as the agent, as the healthcare proxy, will need to revisit goals, revisit plans, and make decisions accordingly. So I'm just going to quickly mention to you where palliative care takes place. It can take place in the hospital, usually in the form of a consult or an integrated program that begins palliative care at the same time as a hospitalization. That's fairly rare. Typically, it's more like a consultation, and a palliative care consult is often initiated when tough decisions need to be made, when people need to be moved away from a curative path and more toward a palliative path. It can be embedded in a cancer center. This is more like a clinic or a physician practice, embedded in a cancer center or a primary care medical home, or as a standalone clinic. Some standalone palliative care outpatient clinics are starting up to really just focus on symptoms and stress. It can be provided at home as an extension of or sort of a pre-hospice program offered by a hospice or a home health agency. There are some standalone palliative care home care agencies starting up. Aspire is one of them. So there are more programs that are caring for patients in their homes with palliative care as, prior to the need for hospice. There's a little bit of palliative care going on in long-term care, not nearly as much as there should be, given the typical profile of a person in long-term care. But consults, palliative care consults may be available in long-term care, or hospice then can come into a long-term care facility and provide that specialty level of palliative care as needed. Likewise, there are community-based services for palliative care. The PACE program, the Program for All-Inclusive Care of the Elderly, is kind of inherently palliative care. Some adult daycare centers offer palliative care. Consultations and hospice also through community-based programs. So it's palliative care is everywhere, and yet not everywhere, because as I mentioned, not every facility offers it, not every hospice offers it, not every hospital offers it. So you do have to kind of go looking for palliative care. Palliative care is important in healthcare reform, and I'll just touch on policy issues here very, very briefly for you. It's important because there is something called the triple aim of healthcare reform that all healthcare reform programs are really kind of aiming for. And the triple aim involves improving a patient level experience. If we're going to reform healthcare, we should do it in a way that improves the patient level experience. It improves outcomes for a population of patients, and by the way, saves money. So this is a tough bullseye to hit. And there's further talk now of the quadruple aim that includes all of those three aims, plus improving the experience for the healthcare provider. So this is really hard. When I was an independent consultant in the tech industry many, many years ago, we used to have a saying, which is, as a consultant, I can give you fast, cheap, or high quality, but you have to pick two. I can't do all three. No. So hitting the bullseye of the triple aim is like doing all three. It's kind of a unicorn. And palliative care actually hits the bullseye, not only of the triple aim, but of the quadruple aim. So now we begin to talk about promises and pitfalls. And I'll try to keep this fairly brief so we have some questions, but there's abundant evidence that palliative care actually does improve the patient experience. It does improve quality of life. It does improve individual clinical outcomes. It reduces suffering. And if it's introduced early enough in some cancer diagnoses, some terminal diagnoses, it can actually extend life. It's not just quality versus quantity. It can do both if it's introduced early enough. So it definitely fulfills improving the patient experience. The hard part is, as I've mentioned, it is insufficiently available and access is not even. The Center to Advance Palliative Care puts out a report card every 3 years, and you can see that there's been tremendous growth in the percentage of hospitals that offer a palliative care program, but it's very uneven across the country. California gets a B, which means we have about 75% of our hospitals over 50 beds that offer palliative care. But there are other parts of the country where it's either non-existent or not easily accessed. So it is very uneven. And as I mentioned, even the quality is uneven because we don't have clear regulations. There is a workforce shortage in palliative care. A few years ago, it was estimated that we had 1 cardiologist for every 70 heart patients. That's a good ratio. On the other hand, we have 1 palliative care physician for about 1,700 patients with serious illness. So that's not a good ratio. And we're really kind of coming around to the recognition that we will never have enough specialty clinicians. So we're trying to get all clinicians trained at some basic level of palliative care so they can be helpful to their patients, whether they're a specialty palliative care person or not. This is a graph from a few years ago that shows the comparison of the predicted palliative physician workforce to the patient need. And you'll see we're actually going to have a bit of a dip coming up here. And I would expect that that dip is actually even sooner as the first generation of palliative care physicians retires and some are getting burned out, like all the rest of the healthcare industry. It's hard to think about improved outcomes from palliative care where we still have a 100% mortality rate, sorry, but it does improve things at a macro level. Definitely reduces readmissions, definitely reduces costs, definitely reduces some of the things that are negative outcomes in the healthcare system overall. And for that reason, as I mentioned, it is in that bullseye of the quadruple aim. But it's hard to imagine what is a good outcome, and we're not very good at measuring it. I will mention there is finally something called Hospice Compare for people who want to compare hospices on quality measures and find a good one. There's no equivalent for palliative care, so we're still trying to measure what's a good outcome and how do we know it and how do we consistently get it. It absolutely, palliative care and hospice absolutely lowers per capita cost at that macro level for the system. And I won't shower you with the statistics, but an average hospice stay is about $11,000, and that's the equivalent of about 3 days in the ICU. So definitely, hospice saves money. Palliative care is starting to show promise in saving money. It's not inevitable, it's not inexorable, but it does happen. But at the level of a particular agency, it's hard to really measure it. And saving money doesn't always mean earning money. Most palliative care programs save money by avoiding costs in another part of the system, not necessarily by producing income for a facility or for a system. So it's hard to make the business case for palliative care. It absolutely exists. There is a business case, but it's not easy to make. Palliative care definitely increases satisfaction for professional healthcare providers working in a team, working with holistic approaches to whole person care, working to relieve suffering has been demonstrated to show higher satisfaction for professional healthcare providers. But at the same time, this work is not for sissies. It's very, very difficult work, and it can be extremely stressful. The burnout rates are very high, and increasingly, we're in the palliative care community paying closer attention to burnout, closer attention to self-care and well-being at an organizational level, not just at the level of the individuals. So what does all this mean for you after a blizzard of, whirlwind tour of palliative care? Well, I'm going to boil it down to four easy things. First of all, trajectories of illness are fixed unless they are intercepted. And palliative care is the interceptor to change a trajectory of illness. It will let you interject opportunities for decision, for thought, for reconsideration of goals, and you won't just get swept along in the inexorable trajectory of a medical system. It allows you an opportunity to have your say. And number two, palliative care is all about you. It really is about your goals, your values, your choices, how you want to live your life, and what's most important to you. Not what's most important to the surgeon or the oncologist or your kid or your spouse or your Aunt Mary. It's about what is important to you and how we match treatments to meet your goals. Palliative care likely won't be offered to you. You will have to ask, but ask. If you are ever diagnosed with a serious illness that may entail difficult treatment, suffering, pain, symptoms of any kind, ask for palliative care. And you will likely be told, oh, it's too early for that. But if it is a really serious illness, it is never too early for palliative care until it is too late. So you will need to ask for it. Sometimes it's called supportive care. But if you ask for palliative care, hopefully you will get it. And if you do get it, it will help a lot for all the reasons that we talked about. So at the end of the day, some of you may remember this gentleman. Some of you may be old enough. Walter Cronkite back in the 70s said, the American healthcare system is neither healthy, caring, nor a system. Palliative care puts the care back in healthcare. It makes it more healthy and more like a system. So with that, thank you very much. I'm going to stop sharing my screen, and we have a few minutes, I think, left for questions if anyone has any.
Jennifer, that was an absolutely jam-packed, full of information presentation. I will start off with the question, do you allow us to post this presentation on our member YouTube channel so that, you know, members that weren't able to be with us today can watch this
Absolutely,
video?
No worries.
Excellent. This was really wonderful. Palliative care, you're always talking about drugs?
No, never. Well, not never. We are always talking about drugs to some degree. And here's how we talk about drugs. One of the things that palliative care does is take a really close look at all of the drugs that you might be taking. And as I'm sure many of you have experienced, when you get to a certain age, the problems start to kind of accumulate, and you might end up taking like the bushelful of medications. And they can interact with each other and they can cause more problem than not. So one of the things that palliative care does is look at those medications and figure out, hey, do we really need all of these? Are all of these contributing to either managing the disease or your comfort? And if not, we can get rid of some of them. And if we do that, it's called deprescribing. Sometimes people really achieve a bounce, of mental clarity or physical function. So we look at drugs in that way. We're very sophisticated with the use of drugs where they are needed and appropriate, such as in pain management. Palliative care physicians are the experts in pain management. And nobody should be shying away from pain management. I know it's really tough in the sort of opioid epidemic environment that we're in, but there are other alternative and complementary therapies. And that's the other thing. So, and that was part of my initial response of, no, we don't look at drugs. We do look at drugs, but we also look beyond drugs. We look beyond them to integrative therapies, massage, music, art, aromatherapy. Some of this sounds a little bit woo-woo, but also dignity therapy, acceptance therapy, some of the things that are helpful in helping people to come to terms with their life. So it's a full toolkit of things that we bring to bear on serious suffering.
Okay, thank you. Thank you very much for that. Is palliative care or supportive care coverage stated in most insurance coverage benefits?
I would say not most, some. Hospice often is, almost always is. There is almost always a hospice benefit in a private insurance plan, although there may be limits on the number of days, or there may be a limit on the top dollar amount. But palliative care per se is only now becoming to get included in some insurance packages. As I mentioned, Kaiser has a good palliative care benefit. Blue Shield of California has a palliative care benefit. Aetna and Cigna and some others are starting to come online with palliative care benefits, but not a lot.
Can you tell us a little bit more about what your institute does? And it's pretty amazing that CSU has an institute doing this.
Yes, yes, we do have an institute. We've been in operation since 2012, and we were specifically founded. We're a statewide institute of the CSU system, although housed at CSUSM. And we were founded very specifically as a workforce initiative to build up more palliative care expertise in the current healthcare professional realm, as well as the future healthcare professionals. So we have kind of a two-pronged approach where we are offering entirely online, but very robust, comprehensive education at the certificate level for the various disciplines that are typically involved in palliative care: nurses, social workers, chaplains, physicians. We offer certificates in pediatric palliative care, as well as primary palliative care and specialty levels. And we have very robust curricula in care management, which actually Rebecca Montano had a big role in helping us develop those. But we also are working in the CSU system to try to get more palliative care content integrated into the undergraduate curriculum, because that's where the real transformation will happen. We're really trying to get palliative care content into our nursing schools, our social work schools, public health, PT, OT, speech therapy, speech language pathology, kinesiology, et cetera, to really build up the palliative care awareness and skill set on behalf of all healthcare professionals.
Jennifer, can you tell me if there were children of or spouse of a family member who's headed in the direction of palliative care, are there opportunities for training that family members could access?
Yes, not from my institute, but from my campus partner institute at CSUSM. We have the Big I Institute and Little I Institute, and we are the main institute, but we have a campus partner institute at CSUSM, and I'll be sure to send you their website link, because they do have caregiver support, education, and training for instance, school counselors. They have a young caregivers curriculum for people who are. We did a study a few years ago and discovered that 40% of our student body were caregivers, for parents, grandparents, even siblings. So caregivers are not only middle-aged and older. So yes, there are resources available from our partner institute.
Great, thank you. I think that would be a very important resource for our membership. I'm asking all the questions here. Let me see if there's another one in our chat. No, it looks like Ished just put up that the contact information. Thank you, Ished. So members, are there any other questions for our guest? All right, I think we've covered it all. Let's see, thank you very, very much for this wonderful presentation. Really enjoyed it. If it's possible that you can send me that link later today, we will send it out with the recording link to all of our members. But this was really informative. Thank you very much.
Well, thank you for having me. I really appreciate being with you today.
All right, and thank you, members, for joining us for this. Take care, everybody. Have a wonderful afternoon.
Thank you.
Bye-bye.